Everybody. I am delighted to introduce to you Dr. Pamela Bowen, and she will be presenting the effects of exercise on brain health, the physical education for an active lifestyle pedal study. And just to get a brief introduction to Dr. Bowen, she is an associate professor, a certified family nurse practitioner, and a scientist at the University of Alabama at the Birmingham School of Nursing. Dr. Bowen is also the clinical director, where she oversees the operation of the Brain Health Advocacy Mission, BHAM, on behalf of the Evelyn F. McKnight Brain Institute at UAB. And the primary objective of BHAM is to actively engage, empower, and educate individuals of diverse backgrounds to facilitate the enhancement and maintenance of their cognitive health and well-being. So this pursuit is of the utmost significance, as it serves as a preventive measure against cognitive decline and the onset of neurodegenerative conditions, including Alzheimer's disease. Dr. Bowen has extensive experience working with a patient population consisting of low-income and African-American individuals who have been diagnosed with chronic illness linked to obesity. These conditions include hypertension, diabetes, arthritis, heart disease, and cognitive impairment. She recognizes the challenges that people with limited resources experience when striving to adopt healthier lifestyle practices, but emphasizes the importance of individualized healthy lifestyle adjustments for the achievement of overall brain and physical health. And with that, I'll hand it over to Dr. Bowen. Thank you so much for coming today, and we're all really very much looking forward to your presentation.
Good morning, and thank you for that warm introduction. So again, I am Pamela Bowen, and as you can see from this slide today, the title of my talk is The Effects of Exercise on Brain Health, the Physical Education for an Active Lifestyle, which is, we named it the PEDAL study. So upon completion of this session today, participants should be able to recognize the significance of exercise to improve overall brain health, become familiar with the scientific premise for our PEDAL study, and to review the acceptability, practicality, and adherence of the PEDAL study. So I'd like to start off with a little background regarding physical activity. As you know, regular physical activity over one's lifetime can be significant. It can provide significant health benefits, such as lowering cardiovascular risk factors, hypertension. It can help with insulin resistance, cholesterol, and it can even help to reduce the risk of premature death. It also promotes mobility and functional independence, which is especially important for our older population in order to maintain independence. And it also can provide some mental and social benefits. But most importantly, activity, especially the more intense activity, it appears to be most protective. And so with the pleiotropic effects of exercise, there are many. And this image was published by Norling and colleagues in 2021. And it illustrates how exercise can positively impact all of the factors that are within the American Heart Association's Life Simple 7 framework, which is used to promote good brain health. Promote heart health. And in the Life Simple 7 framework, you can see that there are 4 modifiable risk factors, and that's when people don't smoke and maintain a healthy weight, eat a healthy diet, and maintain regular physical activity. And then the 3 biometric measures, which are blood pressure, cholesterol, and blood sugar. Physical inactivity is a serious problem in the US. So when you're looking at this map of adults who reported doing no physical activity or exercise other than what they do on their jobs in the past 30 days, the states that are in the dark blue have the highest prevalence of physical inactivity. In fact, the states with the darkest blue have a prevalence of physical inactivity of 26% or more. Excuse me. The top bottom states for physical inactivity are Oklahoma, Arkansas, West Virginia, Mississippi, and unfortunately, Alabama. Regionally, you can see that the states in the South have the highest prevalence of physical inactivity. So this slide here illustrates how Alabama compares to the national average for physical inactivity. And nationally, 23.4% of American adults are physically inactive, compared to Alabama, with 29.1% reporting no physical activity or exercise other than what they do in their jobs in the past 30 days. And I know in clinic, I have so many patients that tell me that I get a lot of exercise on my job. And they feel like because they have a lot of exercise and get a lot of exercise on their job, they shouldn't do any leisure physical activity. So I have to straighten it out. But you can also see that Alabama ranks 46 nationally. And physical inactivity is not only a significant health risk, it is also very costly. As you can see, $117 billion with a B are associated with being physically inactive. And 10% of people who are physically inactive, it increases their risk of premature death. Now, there are several consequences for physical inactivity. It's huge. So there's effects on the body, where you can see, of course, if you're inactive, you're less likely to burn more calories, which means you can gain weight, your muscles atrophy, you have increased inflammation, hormone imbalances. There's just a lot of things where physical inactivity can impact your body. But then it also increases so many of the health risk factors for chronic diseases: obesity, hypertension, cholesterol, stroke. It increases your risk for diabetes, certain cancers, and it can also increase your feelings of depression and anxiety. Obesity, a major risk factor in the US, a major risk factor in Alabama, as you can see. Alabama, obesity is just significant here in Alabama. And when the obesity update for adults came out in September of 2022, it showed that Alabama has a obesity prevalence of 35 to 40%. And within Jefferson County, and that is our primary recruitment area for the PEDAL study, we have a prevalence of 35%. Hypertension, another significant problem in the US. The US has a 32.4% prevalence of people being diagnosed with hypertension. And this percentage is even higher in Alabama. Alabama has a 43% prevalence for hypertension. The states, again, in the darkest blue have the highest prevalence, and that's roughly 37% or higher. The top bottom states for hypertension are Louisiana, Arkansas, West Virginia, Mississippi, and unfortunately, again, Alabama. And if you notice, most of the states have the same high prevalence for hypertension, obesity, physical inactivity, all the same. So what is the scientific premise for our PEDAL study? Based on our original BHAM cohort, hypertension was the most prevalent vascular risk that presented within that cohort. And only 29% reported that they engaged in regular physical activity that was associated with the American Heart Association guidelines. And most importantly, 95% of those who did not meet the American Heart Association guidelines, they selected exercise as one of their lifestyle target behaviors. And the mean BMI for our cohort was 34, which is classified as obese. So this brings us to the purpose of our study, which is to show that exercise works directly on cardiorespiratory fitness and indirectly on other risk factors, thereby improving brain health. We will use the McCance Brain Care Score as our main measure of success, our primary outcome. And our secondary outcomes will include reductions in blood pressure, increases in growth factor, and changes in retinal vascular density. So we hypothesize that our approach will test whether growth factors and retinal vascular density are lower in patients with hypertension, and how exercise might impact or change this correlation. So we will be recruiting participants for our PEDAL study through the BHAM registry. So to tell you a little bit about the BHAM registry, it is the second phase of our original BHAM project. And the BHAM project, the original one, was a one-year project where we enrolled 100 participants from two of our primary clinics, UAB Highlands and UAB Hoover. And then we followed them for a one-year period. So we got this second phase going up and running in August of last year. Now, the registry is a longitudinal study where we will have contact with the participants every 6 months. It would be either in person or we'll talk to them over the phone. And the purpose of the registry is to provide individualized sessions with patients about their current behaviors, health behaviors. So we do a full brain care score on them. We ask them which behaviors they would like to work on, and then we help them develop realistic strategies to improve their self-selected target behaviors, which will improve cardiovascular and brain health. And we're doing this as a strategy to prevent or delay cognitive decline in primary care clinics. So our sessions they supplement what they get at the primary care clinic. And we plan to enroll an N of 1,000. So to take part of the PEDAL study, participants, again, must first be enrolled into our BHAM registry, and they must have the following inclusion criteria. So they must have chosen exercise as one of their target behaviors. They must be between the ages of 35 and 65. They must be physically able to engage in exercise, have a BMI of 25 or greater, must weigh less than 300 pounds, have a diagnosis of hypertension, and they currently must not be engaging in the American Heart Association guidelines of 150 minutes of exercise or greater. So they have to do less than that. Here are the exclusion criteria. So basically, people that are in the study, they can have chronic illnesses, but they have to be controlled. So they cannot have a systolic blood pressure less than 100 or greater than 160. They can't have a history of severe respiratory diseases, uncontrolled asthma, COPD, renal disease. They can't have had a stroke or cancer or head injuries. They can't be a current smoker, they can't abuse substances, and they can't have eye diseases that impact the retina, and they can't have had eye surgery within the past 6 weeks, and they can't currently be participating in an exercise program. So we have a pre-post design with 3 arms, and we hypothesize that after the 10-week intervention, participants who are in the high intensity group will have lower blood pressure, more growth factor, and more dense blood vessels of the retina compared to the participants who will be in the moderate intensity group. And the participants who were randomized into the usual care American Heart Association group, we hypothesize they will have no or very little effect after the intervention period. The measures and measurements that we will use to evaluate the impact of our intervention, we will use the brain care score, the 0 to 21, growth factors, and the optical coherence tomography angiography results. Now, the PEDAL study has 5 different steps. The first step after the informed consent process is the USIM visit, and this is at our UAB Center for Exercise Medicine. And this is where we will draw the blood for the growth factors. The participants will perform the cardiopulmonary exercise test, and this is where we will establish the heart rate growth and determine a general fitness baseline. The next step the participant will complete will be at the UAB School of Optometry, and this is where the OCTA will be performed. The third step, all participants will receive a stationary bike. And because sometimes access to exercise equipment or safe places to exercise can be a barrier for some participants, we want to remove that barrier for all participants so every participant can receive an exercise bike. Participants will register and download a Polar Beat Flow app to their phones, their smartphones, and this is how we will record each exercise session that the participant does at home. These data in the app will allow the research team to remotely monitor the exercise sessions that the participants do. Each participant, regardless of which protocol they are randomized into, will undergo one supervised training session at USIM. And this is where they learn their protocol, whether or not they're in the high intensity, the moderate intensity, or the usual care American Heart Association group. At this session, participants will also have time to ask questions, get clarifications on their protocol as needed. We want them to feel comfortable. So participants who are randomized into the high intensity interval training group, their exercise sessions will entail 1 minute of high intensity exercise, followed by a short period of 1 to 2 minutes of lower intensity exercise. And then this cycle will be repeated for a total of 10 intervals per session. So the intensity that each participant will participate in or follow is determined by their maximum heart rate. And so to get their maximum heart rate, that's 220 minus the person's age. Each session will begin with a 5-minute warm-up and a 5-minute cool down. Now, for people who are enrolled into the moderate intensity group, their exercise sessions will entail 30 minutes at 70% of their maximum heart rate. And this group also will have a 5-minute warm-up and a 5-minute cool down. Now, for the participants who are enrolled into the American Heart Association group or the control group, they will be trained on their stationary bike. They will also have the polar heart rate monitor, and they'll learn about that. And for the 10-week intervention period, they would just be advised to follow the American Heart Association guidelines. And then they are to follow that as best they can. So this slide, I wanted this slide just to kind of show at a glance the intervention. So during the intervention phase, the high intensity group and the moderate intensity group, they will complete 20 to 40 sessions independently at home on their stationary bikes. Participants will engage in 4 days per week for 10 consecutive weeks. Each exercise session will be recorded on those Polar Beat Flow apps and monitored remotely by the study staff. And all participants will be contacted once per week, regardless of which group they're in, because we want it to be consistent between all groups, just for a check-in and to provide guidance as needed. Now, exercise non-compliance is expected, and participants may be withdrawn from the study if they consistently fail to fulfill their randomized group activity level. So non-compliance in the high intensity group and the moderate intensity group is defined as exercising less than 3 times per week for the first 4 weeks of the intervention. And there's no non-compliance protocol for the American Heart Association group. So they won't be excluded if they do not follow the American Heart Association recommendations. And then the final step of the study will include the post-intervention visit. It's the same as described in the baseline and the pre-intervention visit. So that includes the blood draws for the growth factor, the cardiopulmonary exercise testing, the OCTA protocol, and then the full brain care score. So individuals who participate in our pedal study will be compensated according to the following schedule. So all participants, regardless of which arm they're in, they will receive a stationary bike, which is approximately $500, and a gel seat for comfort. And then they will receive $200 for the informed consent, the baseline visit, the pre-intervention visit, and the protocol exercise training visit. So each one of those are $50 a piece. And then they all will receive $100 for completing the post-intervention visit. Now, in addition to the previous $300 that I discussed on the previous slide, individuals who are in the high intensity group and the moderate intensity group arms, they can receive up to an additional $530 for adherence. So as you can see, the more sessions they complete, the more monetary incentives they can receive. And then the less they do, the less they receive, and then they could even get withdrawn from the study. For the American Heart Association group, they just get what was the total of $300 and the stationary bike. There's no money to incentivize them to adhere to the weekly American Heart Association guidelines. So we got our study going, IRB approved and everything. We were starting enrollment in January 15th, 2024. And as of right now, we have enrolled 35 participants total into the registry starting the week of January the 15th. We had 10 people who met the basic criteria for pedal. We had 4 people who were interested in pedal, 4 people who met the full eligibility for pedal, and 4 people who have provided informed consent for pedal. So we have 4 people right now going into this study. I have a potential for 2 people to be enrolled this week, so fingers crossed. And we're just excited that it seemed to be going well. I'm blinded to this study, so I don't know how they're doing. I'm just fingers crossed that they're doing well. All right, so I'd like to acknowledge the McCance Brain Care Center for and the Evelyn McKnight Brain Care Institute here at UAB for funding this study. This is a list of our pedal teams, a great team to work with. And thank you for listening. And are there any questions?
Thank you, Dr. Bowen. Very nice. I don't know, Dr. Singh, would you like to moderate this session? I have a few questions, maybe while Dr. Singh chimes back in.
Okay.
I would be very happy to. Thank you so much for this wonderful presentation. Jean, maybe you would like to start your questions, and I'll monitor if there's anything in the chat in the meantime.
Okay.
Anyone else who likes to have a question, please raise your hand.
Yeah, so Dr. Bowen, could we go back to the your primary outcomes? If I read that correctly, it is the brain care score as the primary endpoint in the trial?
Yes.
And the main aim of the study is to reduce blood pressure. I mean, the brain care score has a variety of components to it. And for the certain sections in terms of aerobic exercise, there's basically a 0 or a 1 for that component. And part of your inclusion criteria is very similar to what's on the brain care score in terms of people that you would enroll that are considered sedentary. Is that right?
Right.
Okay.
Right. Who are not meeting the 150 minutes per week.
Okay. Okay. And the hope is that on the brain care score, you would see that go from a 0 to a 1.
Improve, yes.
Okay. Okay. I'm just wondering, these other secondary outcomes of reduced blood pressure, you expect to see that change as well, but through the construct of the brain care score. Do I have that correct?
Yes. So yes. So we wanted to use the brain care score because we're hoping that by them engaging in this healthy behavior, that the brain care score will improve. And as we know, that usually when people engage in one thing that's healthy, they start trying to improve other aspects of the brain care score. So if they're exercising, hopefully that'll have changes in their BMI, which is also on the brain care score. It might help with their stress level. We're just hoping that the exercise can improve different components of the brain care score, but we're focusing on hypertension.
Okay. Okay. And so I guess part of my question is, do you have information on the brain care score distribution of the study population that you're targeting at this point? Or is it that because you're recruiting from this particular other study? Is that
Okay,
right?
so yeah, so the original BHAM study was the pilot study that we did for 1 year.
Yeah.
And we had 2 groups. We had a group 1 that we had contact with them every 6 months, and in the group 2, where we had contact with them every 3 months. But when we looked at the results of the 100 participants, the majority of those participants had hypertension. They were diagnosed with hypertension. And that's why we wanted to focus on hypertension.
I see.
Based on the results of the original BHAM study.
Okay. Okay. Well, I think I understand now. So I'm trying to get a sense of how you power a study like this in that way. Like, how did you come to a conclusion of how many people you would need to enroll in the PEDAL study based on these criteria?
Well, it's basically a pilot study. So we're not trying to really power. We're just trying to see whether or not this will be feasible and acceptable in our population.
Okay.
And to get some data that hopefully we could use for a larger study.
Okay. Okay, I understand. Thank you.
Okay.
Great. I don't see anybody else with their hands up, but we do have a question from Elizabeth in the chat. And she's saying, thank you. And are you planning on any qualitative assessments, given the challenges on adhering to exercise routine? And then she also has a follow-up question. She's asking, similarly, any way to assess the level of engagement in the brain care score? So since engagement is a key objective of using the brain care score with individuals. Thank you for this great presentation and focus on exercise.
Unfortunately, for this project, we're not looking at qualitative, but it would be great to know qualitative. I primarily do qualitative data, and it's you get to understand what the facilitators and the barriers are, and that's a great idea to have a component as a next step for following up with this project, especially for the ones who, well, I'm not going to speak that into the atmosphere. After everybody does everything they're supposed to do for this study, then we can find out what facilitated them to engage in this 10-week intervention. As far as the second part was, what was the second part of the question? I'm sorry.
No,
About
it was, oh, I'm so sorry.
sorry.
Yeah,
Sorry,
no.
I'm with allergies here. It's hard to talk. Engagement with the brain care score, especially using it on an individual level. If there's any way to assess any kind of level of engagement with the brain care score of the participants, and then maybe any differences in those that are more engaged versus less engaged, or motivation, or anything related to the individual's experience with the brain care score.
Yeah, again, that would be great to, we're not doing that, unfortunately, but that would be great to find that out. We will be able to see their engagement by what the polar monitors that we have. We'll be able to see if they are actually meeting the prescription that they have. Are they actually engaging 4 days a week, which is the minimum? Are they going over the 4 days a week? So we will be able to see some engagement, but as far as what motivates them to really be engaged, we won't know that.
Thank you.
Thank you.
And may I ask one follow-up question?
Sure.
I wrote a grant which was rejected so far, but we're trying to send it to now another agency about actually this whole point about engagement with the brain care score. And one of the things that we proposed, for example, was to not only look at like a change in the brain care score as an outcome, but also in, for example, behavioral intentions. So did people feel like they had the attention to change their behavior? Because, for example, BMI might take a while to really change, but people are in fact exhibiting certain behaviors leading towards that change. So that's just one suggestion. I'm very happy to send you the grant if you'd like to read over it.
Okay, that sounds great. Are you using the I'm trying to think, I've the model that uses the behavioral intention? That's which model are you using? I can see the model.
I don't think we are per se using a model for behavioral intentions.
Oh, okay.
You're just using it like as a different outcome measurement, kind of like an intermediate outcome measurements.
Okay.
If you, yeah, I would love to learn more about the model if you would care to send it my way.
Okay, great.
Yeah, so I'll send it over to you and see what you think. There's also another question in the chat from Nelson. Here in Boston, we are fortunate to live in a very walkable city. I noticed the groups that have less exercise are Sunbelt states that are more car-centric cities. Is there research linking a sedentary lifestyle with living in cities where people walk less?
That's a good point. And that's kind of why we wanted to provide the stationary bikes, because there's so many different barriers, especially here in Birmingham. It could be safety, it could be no sidewalks, there's no green space. I mean, there's a lot of that here. And that's why we wanted to prevent that barrier and use the stationary bikes. So, and in the rural areas, Alabama has a high percentage of rural areas here. So same thing, no sidewalks, safety issues, animals on the loose, those no lighting. So yes, I don't know the statistics for that. I just observational, I know.
Thank you.
So tell me, how do you all get people to buy into the walkable spaces and get the cities to do sidewalks and more lighting, more green space? I would love to know how we can get the people here in the South to do that.
And Nelson, would you be able to answer that question? I'm not sure if you can unmute yourself or not. No worries if not.
Hi, can you hear me?
Yes.
Yeah, it's something like I'm very passionate about, like making cities more walkable. And yeah, it's definitely a challenge in like a lot of cities where like it's more like centered like around like highways and stuff like that. So like it starts with like I would say it starts like very simple, just like if there is like let's say a sidewalk or like some sort of path, like actually just have normal maintenance to like make sure that like people actually use it, and also like encourage more sort of like like have more like these parks and like green spaces like you mentioned before, like yeah. it's a lot of work, but like I think it's something that the United States needs to like more cities like need to invest more if we want people to walk.
I agree with you totally. Totally. Even in a lot of the neighborhoods that are around UAB, which is a medical academic research center, the neighborhoods don't have walking spaces or grocery stores with produce. I mean, there's food deserts. There's a lot of social determinant of health issues here, surprisingly, or not surprisingly.
Yeah, maybe I can comment a little bit just from personal experience, having lived in Portland, Oregon, Boston, Lausanne, Switzerland, these different places, somebody that is very active in myself. It's really, I think, coming down to the city planning and the organizations around city planning, and also the age of the city. I think it's very difficult. For example, Boston is very walkable, but it's not very bikeable, right? So it takes major incentive and tax and incentives and different types of approaches to reconstruct an old city into adding sidewalks or adding bike lanes. Whereas out in Portland, Oregon, it's a younger city, and a lot of the city planning was put in place in the development very early on, and it makes a big difference. But then you have good examples in Europe, which are very old cities that have restructured for a healthier lifestyle in terms of walkability and bikeability and things like that. So it can be done. But I think it's around the city planning organization and leadership there, and certain incentives that can be put into place. For example, making driving more difficult for people in terms of how affordable it is. But then you run into a lot of the same issues, Pamela, you're bringing up about social determinants and issues. So you have to be very careful about these type of programs.
I can say that our city has started incorporating bike lanes. So we do have some of those around UAB.
That's good for the pedal study then.
So if I could just make a comment, if I might. So Sanjala, what is the average age of your participants up in Boston?
So it depends on which study we'd be talking about, I guess.
I'm talking about Boston then.
Yes, it would be depending on like which study you're especially like referring to. Do you mean like reach or which study do you mean, Ron?
So in other words, for those who are participating in primary care, for example, you have.
Actually, I'm not sure about the exact number.
Okay. So the reason why I asked the question is that in most projects around the country, this notion of doing things related to life essential aid and so forth, most of the participants are their 60s and older. But for us, the average age is in the mid-40s. And because we have taken the position that this is a lifelong process, and that's why we engaged in family practice, because they see people over the entire lifespan. But the implication, especially here in Birmingham, is that everybody is working, sometimes 2 jobs. They're taking care of kids, and they're taking care of perhaps an older parent, and they are just full up in terms of their life's commitments. And so how you integrate this lifestyle change, if you will, within the context of very, very busy lives is something we're trying to grapple with. And sometimes it's a single parent that we have to deal with as well. So it's been challenging for us. We are less convinced, at least in our population, this goes back to the question asked before, that the brain care score in of itself is going to be motivating. I think it's going to take more than just knowledge. And in fact, if you ask a number of participants in our group now, they know they're not getting enough exercise. They know they have high blood pressure, but they don't necessarily engage. And so how do you go from knowledge to engagement is something that we're trying to tackle with as best as possible, especially if you want to bring it to scale. So, so these are challenges that we have that I think it's more than just understanding the relationship between these factors and, cognitive decline, stroke, and late life dementia. it's more complicated, at least in our population.
And that
And-
qualitative component, I believe would help with that, because I think that you have to ask the person what motivates them, or what's the barriers for their motivation, because everybody is different. No one's the same, and there's no one all fit all. So I love that idea of adding a qualitative component. And I'm sorry I cut you off.
No,
That's okay.
not at all.
And so,
Oh.
and one other thing we found in our initial 100 is the number of individuals who have a history of anxiety and depression. And so we have incorporated a brain health consult, if you will, a behavioral consult to work on stress management. But we think that's a really important barrier that we're just beginning to learn about, especially down here where the disparities are so extraordinary. And so if doing an intervention there makes a difference in motivation, then perhaps we'll make a big breakthrough. But that's something we have yet to learn about.
Great. Ron, just to quickly address also your motivational question. So for example, in the same grant that I was just talking about, we talked about incorporating these psychosocial techniques to actually address motivation firsthand. For example, to have like these intimate intentions, setting and implementation, like a value-based affirmation exercise. Are you thinking along those same lines? Or what do you think can bring people from knowledge, the actual motivation and actual behavioral changes?
I thought I was going to learn that from you.
Yeah,
To tell you the
hopefully in the
truth.
future.
But you know, if you look at most interventions for hypertension, which is the most common, or a controlling diet, they really have not been effective. They have not really shown much difference. And 50% of all healthcare apps are no longer used after 6 months. So there is a gap of knowledge there about engagement that we're trying to learn more about, and we don't have really answers right now. That's why we're paying people as much. That's why we're giving them the bicycle. But you can't do that for a large population. So how Walter will do that in Derby, Connecticut is you know, that's 15,000 bicycles. So that's not going to happen. So we're, you know, maybe Pam, you have some thoughts about this, but I know that's a struggle for us.
Thank you, Ron. That makes a lot of sense. I'm looking, there are no more questions in the chat that I can see at this moment. Is there anybody else on the call who would like to ask a question or has a comment?
While we're waiting, the theory of planned behavior is the model that I was thinking about. It talks about the behavior intention. So we should talk.
Again, I would love to talk. Could you tell me the name one more time? I'll write it
It's
down.
the theory of planned behavior.
Great. Thank you so much. Amazing. Thank you so much. Jean, I'm looking at you as well. Should we maybe hold the chat open for a few minutes to see if any more questions pop up, or shall we give everybody 10 minutes back of their time?
Yeah, I think if there's no further questions or discussion, we can give everybody their time back. You know, I just say thank you so much, Pamela. This has been really a wonderful presentation of this feasibility and pilot study. I look forward to seeing some of the results. Some really interesting comments around obstacles and it's a unique population as well. And you know, the prevalence there in Birmingham and the populations you serve, it's, you know, do you have an idea of when this study would report some results in terms of timeline?
Well, it's a 2-year project, so hopefully we should have something beginning next year.
Okay. All right. Well, we look forward to that.
Okay.
Thank you so much.
Thank you for having me.
Thank you so much. It was really wonderful. Have a great day, everybody.
Bye.
Take care.